I want to talk a little bit of the gross anatomy of the TMJ. Again, this is all basic stuff, which I think, some of you now, I'm pretty sure in the previous programs of BSPT programs past, I would say 2000, because of the inclusion of several topics in our musculoskeletal courses. I'm pretty sure that most of you have have gone or studied the anatomy of the TMJ. So we know about the TMJ, but next thing is we want to know how to treat the TMJ. Okay, whether that's whether it's a problem on its own or a problem as a whole. So again, I wouldn't just go through all of these structures, but again, we want to look at the articulating. What is the joint composed of? Okay, so your TMJ is composed of the mandibular fossa of the temporal bone. Okay, so as you can see there, and which articulates with the condylar head of the mandible. Okay, so if you can see around with our model here, okay, so that's your temporal bone, mandible bone, and you have the articulation. That is your TMJ out there. So now, a little review of the anatomy as well is what do we know about the TMJ? A TMJ is a diaphragmatic joint, and it's a hinge joint, okay, just like the hinge of the door, okay, and it's also a synovial joint, meaning there are pain-sensitive structures around the TMJ, and with having a synovium means that it can be affected by inflammation, okay. Now, as far as the disc, okay, that's one of the most important structures of the TMJ is the articular disc, which you will see in this slide. I think you'll see that in this. So the disc is actually is more. It looks like you can also look at it as like a buffer. Okay, if any joint of the body has cartilage, your disc would be the shock absorbing mechanism of the TMJ. And the articular disc is biconcave. The joint capsule, which encapsulates the entire joint, is protected, is strengthened by all the passive restraints. Okay, you have collateral ligaments, you have the disc, and you also have the retrodiscal tissue. So our question now is, which part of the disc of the TMJ is nociceptive? Which parts are based on studies, pain management studies, they found that the retrodiscal tissue is highly vascularized and innervated. So your retrodiscal tissue it connects to the posterior part of the disc and attaches here. And they, based on pain pain studies, they determined that the most painful part of the TMJ is your retrodiscal tissue because of its of its structure. So what happens is when you irritate the retrodiscal tissue, okay, then that produces pain. Now, obviously, these are just not it. It's very hard to determine. It's not going to be clear cut as to for someone or for a healthcare practitioner to say, not even a doctor to say, okay, that's what's hurting now is your TMJ. It's a retrodiscal tissue. There's so many things around that whole area that can actually contribute to pain. So that's why it's not clear cut. Unlike other parts of the body, like the peripheral joints, for example, it's clear cut. We know it's a muscle tendon issue or a cartilage issue, but which is prone again to compression or compressive forces on the joint can actually irritate structures. The same way the TMJ is built. Okay, compressive forces on the TMJ, okay, can produce pain. It can damage tissues. It can damage the disc. It can damage it can distend the joint capsule, and again, a lot of times it can also affect the muscular system or the muscles of mastication. So arthrokinematics is really just looking at how the joint moves. Now, these are important. This is very important to know, because when you begin to perform, and when you start performing interventions on the TMJ, manual techniques, you know, we always want to know that we're actually moving in a direction that does not put in, you know, undue strength into the joint. So, you know, just like any joint of the body, we need to know the arthrokinematics. Okay, so the two main, I would say, motions or movement in the TMJ is rotation and translation. All right, so you got to remember this too. There's the joint, when the mouth opens, the joint, okay, the condyle rotates, and then with full mouth opening, the mandible translates forward, okay, or anteriorly. Okay, so very important to understand, just like how we want to study the joint, the shoulder, for example, when we start doing any kind of mobilization technique or anything of that matter, we need to consider the arthrokinematics, okay, concave, convex, and things like that. But this is very easy to see, and it actually is very simple to understand. You just have to remember that the joint, okay, the joint rotates and then translates during mouth opening and closing. The articular disc also translates anteriorly during protrusion. Okay, so you know what protrusion is. We're going to review that in a bit. And then it rotates posteriorly during retrusion. So protrusion is bring the jaw forward. Retrusion is bring the jaw backward. Lateral excursion involves rotation of the ipsilateral condyle and translation of the contralateral condyle. So I mean, it's going to be a little confusing when we want to visualize all of these, but again, lateral excursion for, you know, just as far as my my opinion on that matter is, you know, that's a movement that is very minute, okay? But there is lateral excursion, okay? You need to have all component movements for the jaw to open, but it's actually not a functional, I would say it's a movement that we on a daily, you know, on the daily, on how we function daily, we don't necessarily need to do a lateral excursion of our jaw, okay, unless we do something else. Okay, so so a little overview of the arthrokinematics. Now I have a little here, if you notice, DDWR, and these are just all shortcuts of disc derangements, okay? So these are two conditions that we see. It's a pathological condition of involving the disc. So DDWR means it's a disc derangement or a disc displacement with reduction and a disc displacement without reduction. Okay? So now I'm not going to, as part of the score of this presentation, I won't be able to really talk much about DDWR or DWOR. These are, and again, I have to be honest, since I started treating patients with temporomandibular disorders, I've basically only had one patient who had a disc derangement, okay? So you just have to recognize the signs and symptoms of a disc displacement, okay? And we'll talk about that in the next few slides, okay? But it is something that we don't see a lot, but it can happen. So we want to also recognize the link between the upper cervical spine and the TMJ. You have the trigeminous cervical nucleus C1 to 3 and the TMJ innervation. They all share the same innervation, and symptoms can overlap, and differential diagnosis is very essential for this. So the significant association between upper C-spine dysfunction and TMJ disorders. There's a high prevalence of vertigo in TMJ patients also ringing in the ears. Okay, and anecdotally, treatment of the upper cervical spine improves TMJ pain and active range of motion. Now, when I mentioned earlier that it's very hard to just learn, or not hard, I would say I would say it's a waste of time to just have a course on the TMJ alone, because talking about the TMJ exclusively without talking about the entire the cranial and facial system is, it's very important for us to look at the bigger picture. Okay, so that's why we need to include the cervical spine in our assessment. Okay, so this is what we do. Evaluation is, we're all good in doing an initial evaluation. Now, I'm hoping that after this presentation, I'm going to present this whole, the evaluation of a patient with TMD. Again, this is, I'm going to just show you a simple case, basically. Okay, this is not going to be complex, but I want everyone, for those who actually go back to treating patients on Monday, is look into your initial eval form. Okay, so I'm sure all of you use the same form for ortho patients or neuro patients or say pediatric patients. But again, you have to know, if you have a patient with TMJ, with a TMJ disorder, or a patient exhibiting symptoms in the craniomandibular region, you need to know which part of your assessment you need to document. Okay, so in your evaluation form, you always have the history and shift complaint, which is very important for us to determine we need to have a working hypothesis. Okay, so by asking key important questions in the history and important questions on patient's chief complaint, you'll get the whole picture at least by 50%. Okay, you'll develop a working hypothesis as to, okay, this is what I'm going to do next, or what I'm going to, or this. Now, the patient examination involves all the physical aspects of our examination. Okay, whether that's active range of motion, passive range of motion, some of the special tests, some of the neurological assessment that we do, and all those things. I have this little cartoon strip here that says, if you all you have is a hammer, everything starts looking like a nail. And I used to have I have a colleague actually back. She's no longer with the clinic, but when we were still. She would, and this was something that I would just notice, and she would basically, even before doing an evaluation, she would look at the diagnosis. Okay, so, and before even examining the patient, before she even starts the evaluation, she already has all these exercises and treatment interventions ready. Okay, so it's almost like, okay, it's almost like just matching your treatment interventions with a specific diagnosis, which is not, that shouldn't be the case. Okay, that is entirely the wrong way to actually do things as a physical therapist. Okay, and again, that's just one the argument of, okay, do we actually want to know everything that we need to know as far as the anatomy, the biomechanics? I want to know the pathology involved. We want to have imaging reports and things like that in order to make an informed decision on what to do next. That's usually not best practice, but again, I want everyone to know how to ask questions, or what questions to ask if you have patients with a TMJ, with a patient with TMJ problem. Okay, so history and chief complaint. These are the 5 key questions that we want to ask. Okay, if you're not asking any of these questions in your daily practice, start using them. And I guarantee it will give you a clearer picture on and knowing what how to begin, or how to begin the examination on what to do next. Okay, so mechanism of injury, again, that's very standard. Okay, we always ask how symptoms started and things like that. The mechanism of injury does not necessarily need to be anything traumatic. It could be, you can have patients who come in and say, okay, when I started having pain in the jaw that started 3-4 weeks ago for no apparent reason. Okay, so and what do you do next if there's no mechanism of injury? So you have to investigate further. Now, location of symptoms can also be localized or diffuse. So when you have a true TMJ problem, okay, if it was mainly a problem associated with the disc, okay, or the joint itself, you will have pain in the preauricular region. Okay? And we'll practice some of those. I'll show you some of those in my next few slides. So localized symptoms that are localized can simply point us to the direction of, well, it is a joint. Okay, same thing like the other extremities. Okay, if you have, and I also like to just mention the shoulder each time because again, it's pretty straightforward, clear cut. You know what's going on. You know what tissue is contributing to the patient's pain. So again, this is just an example. If you have a patient with a shoulder problem, a true shoulder problem, they'll have pain pretty much in the joint, okay, or within the region of the joint. Now, if the symptoms are diffuse, that's another thing. Okay, so you have to determine whether that pain, say diffuse, it's non-localized. Okay, it can be felt anywhere in the arm or even down the arm. So that can lead you into looking at the cervical spine, because we all know that pain from the cervical spine can generate pain down the arm. So location of symptoms are important. Now, before I actually continue, I want to ask, or not ask, I won't be able to get all your answers, but I am hoping that during your initial evaluation, in your initial evaluation form, you have a diagram, you have a body diagram, okay? And that's very important for patients to fill out, or it could be you asking the question and have the patient draw, and basically mark the areas of the body that they're having pain. And that will help you in actually further discriminating, where the symptoms are, what is generating the symptom. So nature of symptom could be constant or intermittent. Okay, so intermittent pain that comes and goes, and usually tells us that the problem could be mechanical. Okay, so if the problem is mechanical, we can fix it. Okay, now if you have symptoms that are mostly constant, it's always there. Whether when you wake up in the morning, it's felt in that area all the way until the evening. You have to look further into the patient's history to see if there's there's an inflammatory process going on or a degenerative process. Okay, so again, these are things that will lead you into or get you more into a mindset of differential diagnosis is a favorite subject which I teach and talk passionately about. Yes, again, treatment is actually the easy part, okay? But knowing what treatment works for a patient that's the most challenging part, because you need to know. You can't have a one-size-fits-all treatment approach. Okay? That tells us that we need to be efficient. We need to get to the problem quicker and treat it. Behavior symptoms, again, better or worse, we already know. We know how to ask those questions. Okay, it's very standardized in our evaluation form. And duration of symptoms, acute or chronic. Okay, we want to know again when the condition started, when the symptoms started, and how long has it been going on. So chronic, and this is where actually perpetuating factors come in, because when you have patients who have a chronic onset of symptoms, you want to look into how it affects their function now. Okay, so and a lot of times there will be instances where you need to screen for psychosocial issues when that happens, okay? Especially when patients are have been taking pain medications, okay? So those are just things. So always consider cervical spine contribution in our assessment. Okay, mechanism of injury. Has this film been shown in the Philippines? Yes, no? Have you guys seen this movie? Nobody? No. Yes, no. Anyway, it's a funny movie. If you get to rent it or watch this movie. Okay, mechanism of injury. There's three things. Okay, we need to find out. Okay, we need to know if. Okay, when you say trauma, okay, trauma would be, and it could be anything that predisposes the symptom. Okay, so you have macro trauma and micro trauma, and then again and you'll have a proportion of patients that have no trauma or no predisposing factor, but have pain. Okay, just develop on its own. We could just be waking up one morning with pain in the jaw. Okay, so but again, we need to find out. Look deeper into their history and see whether they had any micro traumatic event or a macro traumatic event. All right, so examples of macro trauma, you'll have dental work, surgery, and again, direct trauma there. Now, and again, one of the cases that I'll present later on is of a patient who had started to develop symptoms again after seeing a dentist, okay, so having dental work. Now, surgery could also be part of micro trauma and direct trauma. Obviously, someone gets kicks in the face or somebody gets hits in the face. Now, micro trauma, and this is where, again, we need to really investigate. Macro trauma is easy to they'll tell you exactly when it started, okay? But for micro traumatic events, you'll have to dig into their habits, okay? So we would call habits, the term that they use in orofacial management is parafunctions, okay? So these are detrimental oral habits, parafunctions, which can lead to overuse and again, anxiety, and people who tell you, okay, they get really tense and things like that. That can contribute to, again, prolonged trauma, okay? Again, when you say trauma, it doesn't necessarily mean a blunt trauma. It could be something that predisposes the patient to a condition that needs to be reversed. Okay, detrimental oral habits are simply called parafunctions, which lead to overuse. Okay, so again, you have nail biting, mouth breathing. Okay, a lot of us breathe through our mouths when we sleep. Okay, again, these are all just habits. Okay, some of these habits may have started when we were young, all the way until adulthood. I said again, I recall having a classmate back in high school who likes, sucking their pen. Okay, so I'm not talking about thumb sucking, but pen sucking. Okay, so these are things that can perpetuate. Now, obviously, we don't know if they eventually develop into if these people eventually have TMJ problems down the road. But again, these are questions we need to ask our patients as far as parafunctions. Okay, you'll have patients who like chewing gum, okay, constantly throughout the day, and that can lead into overuse. Okay, a lot of these parafunctions, okay, these habits can, when we say overuse, this primarily will direct you into more of a muscular issue, okay, most of the time, okay. Again, and that's why we need to start categorizing or classifying our patients into what group they belong to in order to find the best solution or find the best treatment approach for these patients. Okay, other specific questions in history. Okay, so you want to know if they have any history of extensive dental work. Okay, is the patient using an orthotic appliance? Okay, mouth guard, or patients who've had retainers or braces, okay? It's a different thing now because a lot of these things can, patients who've had the first few weeks of having braces actually can develop pain in the mouth, okay? Pain in the jaw, pain down the upper and lower jaw, and things like that. But again, a lot from the onset of having braces, some patients may actually have retainers too. And if the retainers actually are poorly fitted, okay, that can also contribute to pain in the mouth, pain in the jaw. But again, this is probably something that we don't, it's not our scope of practice to do any interventions as far as the mouth. But again, we need to just know or determine if all of these are contributing to the patient's symptoms, right? And if it does, we need to contact the medical specialist right away. And in this case, it would be the dentist. Now, are there any perpetuating factors such as nutritional, metabolic, psychological infection? Bad habits, again, we talked about parafunctions. Those are things we need to find out. Do they have missing teeth? Okay, so, and this is really interesting because again, I would say, but this is a good 10 years now. I actually lost, my molars were actually impacted on all fours, okay? So they had to remove that. And the back portion of my tooth, the upper part, had to be removed as well. And so the dentist, the oral surgeon actually said that, okay, we'll have to remove the lower part of the teeth too. So I was kind of wondering why they needed to remove my lower molar because I was missing an upper molar. And he explained to me, the dentist, the oral surgeon explained to me, well, you'll have unopposing teeth, okay? So which in my mind, I was saying, okay, well, so what if you have unopposing teeth? And so I think there's a biomechanical reason for that, of having, if you lose a molar on your upper jaw, they'll have to remove the lower molar as well so that you don't have unopposed forces, okay, when we chew food or when we close our mouth. Okay? So oral habits could also be chewing gum and sustained postures. Okay, so again, this is very important in terms of looking into the entire picture and looking at the our patient profile. Okay, observation of the posture. Specific questions related to TMJ. Okay, is there pain with mouth opening or closing? Okay, is there pain with chewing, biting, and yawning? Is there clicking, popping, and locking of the jaw? Okay, the third question here, clicking, popping, and locking of the jaw is indicative of a disc displacement, okay, a disc derangement with reduction or a disc displacement without reduction. Recall the slides, the previous slides, and those are one of the things that need to be, we need to look into that closely because again, treatment for that, treatment for a disc derangement with or without reduction involves, it's not a quick fix, okay? So we need to progress our management and for these patients, okay? And unfortunately, I consider that more of a complex problem, okay, which needs, again, it takes time, several sessions of therapy, okay, and management, okay, whether it's manual or not, or exercise. Again, but unfortunately, it's not part of my presentation because, but if you are, again, if you're a PT who is planning on developing a practice specializing in TMJ and craniomandibular disorders, look into our courses down the road for advanced. Hoping, we're here to provide that training for you. Okay, components of the physical exam. Okay, these are again the typical areas of our initial evaluation. Okay, we always want to look at posture. We want to screen for or look at the cervical spine. Okay, when I say screen, we also need to involve some movement. Okay, it's not just asking questions. We need to include a cervical spine in our assessment. Okay, so we need to, and then we need to do the active range of motion part. repeated movements, passive range of motion. We need to be able to do a joint mobility assessment or a joint play assessment. Yeah, we need to be able to do a muscle performance testing, okay, or simply your muscle manual test. And we need to be able to palpate those structures, okay, that is, well, palpation mainly is directed to the muscles of mastication, okay? So I'm looking for trigger points and all that. Now, special tests also, and again, our cranial nerve assessment for those patients who are exhibiting CNS lesions. Okay. Again, that would be again a part of our systems review. Now, here's a little. This is just a little, not an experiment. This is a little nice thing to know, to learn and observe, okay? So all of you now, I guess you're all sitting in front of the computer, okay? And I want you to slouch, okay? I want you to be in this position. And everybody go into a slouch position, okay? So when you're slouching, your head goes forward, right? Okay, just like me right now. Now, while you're in that position, I want you all to open your mouth as wide as you can. Can everyone do that? Okay. Now, go into a upright sitting position like this diagram here, or like this drawing here. When you're up in that position, I want you to open your mouth again. And what do you notice? Let me see. Can anyone chat in that chat box there? What do you notice when, as far as your mouth opening in these both positions? What do you notice? Okay, much easier. Very good. It's easier to open. Very good. Sakit pa nga ko, Doc. Okay, so we have a patient here. Okay, this, who is this? Oh, I think I know who this person is. Anyway, so everybody says here, as far as the observation, you can open your mouth wider, bigger when you're in an upright position. So this is just, it just tells you the relationship of the cervical spine to relatively your mouth opening, okay? So if you have patients who are coming in with a jaw problem, okay, they tell you, masakit yung jaw nila when they open their mouth. What do you do next, okay? Obviously you do, everything from your history, chief complaint, and all these things. But look at, when you get into the cervical spine component screening of it, check to see their posture, okay? Have them open up their mouth in both positions, okay? That's one way to find out whether their cervical spine is contributing to their problem, okay? Okay, thank you for that. I'm just gonna minimize, all right. Okay, so to continue our cervical spine screening, we wanna also test neck retraction, okay? So again, this is just going to the shortcut of things, but again, you want to test all movements of the neck, obviously, okay? So that's just typically what we want to look to see if their cervical spine has full range of motion, whether in rotation, flexion, extension, and two very important movements is protrusion and retraction, okay? So for patients who have pain in that whole area, okay, this is where, again, you want to find out whether their symptoms are actually localized or diffuse. But obviously, if they have pain that's extending from their upper cervical spine, that really clearly tells you that they have the neck problem. But also, and what I find in my practice, as I see these patients coming in with a jaw problem, okay, simple jaw problem, let's say, which started 2-3 weeks ago. So they're in acute phase. They don't have other issues except opening, they just have pain when opening their mouth. So whoever that was who said masakit yung panga nila when they open their mouth, okay? So try to do this exercise right now. I want you to start doing neck retractions, okay? You need to see it on a lateral view. Can you see that? Okay, so make sure you can do neck retractions several times. Okay, so usually I hold that retraction in for about 3 seconds. Now, if you do about 20 of those, for those who actually had pain earlier when they were opening their mouth, okay, do 20 neck retractions and then open your mouth and just tell me. You can type on the chat board and just tell me what you find. Is it same, better, or worse? Now, I'm just going to go ahead and continue to the next screening test that I usually do for patients with pain in their TMJ or facial region. Now, I think some of you are probably familiar with the flexion rotation test for cervicogenic. I'll just make use of this with proper reference to Physical Therapy Nation, but I'd like you all to see this, okay? And I'm going to play this video right now, and this, again, for the flexion rotation test.
This is the flexion rotation test used to identify movement dysfunction, the C12. The patient's supine, flex their lower cervical spine, and then flex their upper cervical spine. Maintain full flexion, rotate the patient's head to one direction, rotate patient's head to the other direction. The clinician is specifically looking for reports of pain or limitation of motion. So for example, if right rotation is limited, there's movement dysfunction on the right C12 joint. This is a highly sensitive and specific test for identifying movement dysfunctions of the C12 joint.
Okay, very good. Hope you guys saw that. Just let me know if you didn't hear any, but I did adjust the sound of it. Okay, so again, those